I'm Erica Spotts of the Office of Behavioral and Social Sciences Research in the Office of the Director, and I'm quite pleased to welcome you this afternoon for what promise to be two very, very interesting talks. The Matilda White Riley Award and Lecture is given approximately yearly in honor of the late Matilda White Riley, who is no relation to our current acting director. Dr. Riley was the Associate Director for Behavioral and Social Research at the National Institute on Aging, while also providing leadership across the NIH in her role as a chairperson of landmark committees regarding health and behavior. In these capacities, she served as Senior NIH spokesperson on the Behavioral and Social Sciences, encouraged coordination among NIH institutes, oversaw the production of numerous reports to the Congress on behavioral research at the NIH, provided advice to several NIH directors, and initiated the Behavioral and Social Sciences Seminar Series at the NIH, thereby laying the groundwork for what is now referred to as the Office of Behavioral and Social Sciences Research. This award honors an individual whose research has contributed to behavioral and social scientific knowledge and or the application of such knowledge relevant to the mission of the National Institutes of Health. The recipient's research reflects Matilda White Riley's commitment to research characterized by values such as strong linkages among theory, methods, and research topics, recognition of complexity of and the dynamic interplay among processes at multiple levels of explanation, encouragement of research on behavioral and social factors in physical health and of the application of such knowledge in clinical practice and health policy, advocacy of life course perspectives, both at the levels of individual and of societies, emphasis on the potential for improving the lives of people in society, the conceptual expansion of health beyond biological outcomes to include effective functioning, such as cognitive, affective, and social functioning and quality of life, an optimistic view on the ability of social and behavioral science to develop interventions to improve the lives of all ages. Before handing this over to Bill Riley, I'd like to thank this year's selection committee, which I chaired. We had a lot of excellent nominations this year, so we were involved in many lengthy discussions and we had very hard decisions to make. So if I could just, if the members of the committee are here, I would like to give a round of applause to David Chambers, John Phillips, Lisa Onken, Rebecca Clark, and Bill Klein. So we give them a quick round of applause. And now I will turn it over to Bill Riley to present the awards.
Thank you, Erica. And again, thanks to the selection committee for the efforts that they put into this. That's quite an effort every year to go through all the potential people who are prominent in their field of behavioral and social sciences, and from that select someone for the Matilda White Riley Award every year. This year they came to me and said, we've got two, we can't choose. And I said, oh, of course we can choose. So let me look at them and I'll try to make a decision. I couldn't choose either. And so as a result, given we decided we would take an exemption from the fact that it's the 20th anniversary of OBSSR and actually have two Matilda White Riley awardees this year. What I'm going to do, just to kind of get people a sense of this, is that we'll do the awards first, and I'll do it for Jeannie first and then for Kevin. And then Kevin will give his lecture, and then after that, some time for questions. And then Jeannie will give her lecture and then time for questions again from there. So. First off, I want to acknowledge Jeannie Brooks Gunn. She's the Virginia and Leonard Marks Professor of Child Development and Education at Columbia University, and she's the co-director of the National Center for Children and Families and the Columbia University Institute for Child and Family Policy. Dr. Brooks Gunn has contributed substantially to our understanding of family and community influences on the development of children and youth. She has designed and evaluated interventions aimed at enhancing the well-being of children living in poverty and in associated conditions. She's published over 500 articles and chapters, and her current work involves several large research and intervention projects, including a follow-up evaluation of Early Head Start in the Infant Health and Development Program. So please join me in awarding the Matilda White Riley, 8th Matilda White Riley Award to Jeannie Brooks Gunn.
Thank you, Bill.
You're welcome.
Great, thanks.
Thank you.
Perfect.
All right, and then our second, 8th Matilda White Riley awardee, Kevin Volpe. He's the Professor of Medicine and of Healthcare Management and he's also the director of the Center for Health Incentives and Behavioral Economics at the University of Pennsylvania. Kevin has contributed substantially to our understanding of the impact of financial and organizational incentives on health outcomes. He's published over 100 peer-reviewed articles, including recent publications on the effects of co-payments on healthcare and outcomes, the use of default options for shaping provider behaviors, and financial incentives to address a range of health behaviors, including home-based monitoring, treatment adherence, physical activity, weight loss, and smoking cessation. So it's my pleasure to present the 8th OBSSR Matilda White Riley Lecture Award to Kevin Volp. Thank you, Bill. You're welcome. So without further ado, because you came here not to hear me or to see awards, but to actually hear two very prominent scientists in their area speak on the research that they've been doing, and I'll turn this over to Kevin Volp from the University of Pennsylvania. Kevin?
Well, thank you, Bill, and thank you to all of you for being here and for your support over the years. I didn't have the good fortune of knowing Matilda White Riley, but one thing that's readily apparent when you look her up is what an impressive person she was. She had, in essence, multiple distinguished careers. First, as an academic, she authored, I believe, 16 books. She was a university professor at Rutgers. She was the first full professor at Bowdoin, who was a female. And then at age 68, she came to NIH and really, over the next 20 years, spearheaded a lot of very important new initiatives around social and behavioral science and research at NIH, to which I think we all owe a debt of gratitude for her really laying the foundation and giving us the opportunities to try to make a difference through our own work. I also want to thank Richard Sussman. Richard, of course, is a person who's familiar to all of you, and I did have the good fortune of getting to know Richard over the years. And he was, there are many things one could say about Richard in terms of his contributions. I want to just highlight how helpful he was to us when we were starting out in this field, and he was relentless in his encouragement of behavioral economics and health research, and really, I think, encouraged many of the people in the field to get galvanized and really think about how their work could be helpful in terms of improving health and health behavior. And he really, I guess relentless is probably a good word to emphasize. I remember many times getting emails from him at 1 in the morning, and I just thought, wow, he really has a lot of energy. But at any rate, we're all very grateful to Richard and for all of his efforts to really try to help grow and build this field so that we can have more impact in terms of improving the health of not only Americans, but people worldwide. So where I'm going to start my talk is really by highlighting what I think is going to be a major shift in how healthcare is financed in the U.S., because I think this is going to have profound implications for social behavioral science research in terms of creating new opportunities to have more impact in the future. And in essence, many of you may be familiar with this announcement that was made by the Health and Human Services Secretary, Sylvia Burwell, a few months ago. But for the first time, CMS set explicit goals for the proportion of Medicare payment that's going to be shifting from fee-for-service to various different types of mechanisms in which, in essence, there's responsibility for the health of populations of people. And to summarize, with one of the quotes that came with this release was that in alternative payment models, providers are accountable for the quality and cost of the services, people, and populations they serve, moving away from the old way of doing things, which amounted to the more you do, the more you get paid. I think the motivation for this, a lot of it comes from these types of international comparisons where, as you know, we spend a lot more than any other country on health services, but we don't rank very well when it comes to various metrics of population health. So for example, in this Commonwealth Fund study, one can see compared to other Western European countries and Australia, we actually rank near the bottom on a number of health indices, which is obviously not where we'd like to be. And a lot of this probably does have to do with behavior. We know that we have very high rates of obesity in our population. Smoking remains the leading cause of preventable mortality, killing about 430,000 Americans per year. And a very large portion of healthcare spending is believed to be tied to various diseases where behavior plays a very large role. People have tried to estimate how much of premature mortality in the U.S. is due to health behavior choices, and it's very hard to know what these percentages are because there's very complicated attribution issues. But I think the most commonly used estimate is 40% of premature mortality is due to behavior, which really highlights both that there are enormous challenges here and enormous opportunities. So in studying motivation, what's become very clear to us is that we've been on a very interesting journey. For a long time, and I think this is still very much true in clinical practice today in the US, the modal approach is to give people information and assume that if you give people information, they'll know what to do with it. And I think that's partly true, but information in some sense helps to address knowledge deficits. It doesn't necessarily address behavior deficits. So for example, when you look at smokers and what do they know about the risk of smoking, it's pretty clear that smokers in general understand that smoking causes cancer of various kinds, smoking causes heart disease. That information alone is often not enough to get them to change their behavior. Perhaps as a result, there's been a shift towards using standard economics in a lot of different ways to try to influence behavior. We've seen in the last several years a huge growth in employers' use of incentives for health behavior. About 85% of large employers in the US now use incentives for health behavior of one kind or another. The problem with a lot of these programs is they're really couched from the lens of standard economics, and in essence are assuming that people are perfectly rational. They're able to calculate the risks and benefits of their actions now and in the future, and then through some process of backwards induction, figure out which set of choices has the highest net present value. And unfortunately, most people don't make decisions that way. It's become increasingly clear that people tend to be predictably irrational. What's good about this, in a sense, is that it is predictable what sort of decision errors people tend to make. They tend to focus much more on the present than the future. They're very susceptible to framing how choices are framed. They're much more influenced by losses than by potential gains. They're influenced heavily by how they feel as opposed to deliberative cognitive processes. They're very influenced by what people around them do. And they're also very influenced by the choices that are put in front of them, how many choices there are, what order they appear in, what the defaults are. And all of this is a much richer texture for thinking about descriptively about human behavior, but it also has very important normative implications in terms of thinking about how one might design interventions so that they work in terms of trying to help humans change their behavior. We've thought a lot about what types of decision errors can be helpful in terms of improving program design, and these are just a few of them. One of the most important is the notion that people have what are called present bias preferences. So they're much more affected by the immediate costs and benefits of their actions than the future consequences. And this is very important because a lot of programs are designed so that they do things like give people feedback at the end of this year. But of course, if it's a cold day in January and you're trying to decide whether to go to the gym today, the prospect of getting a reward at the end of December isn't very motivating. And you have to figure out how do you make feedback much more frequent, much more immediate. Another very big issue is the framing and segregating of rewards. So we know from a mental accounting standpoint that people process flows of money very differently depending on how they're packaged, how they're bundled. So for example, if we give somebody a $100 discount off their health insurance premium, that gets added to their paycheck. It's electronically deposited in the bank, and in essence, you've made $100 pretty invisible. Whereas if you hand somebody $100, then even if they're a high-income person, they will notice that. Overweighting of small probabilities is very important. We know people are notoriously bad at estimating probabilities, particularly probabilities near zero. A lot of this relates to the popularity of lotteries in the United States. Americans spend about $72 billion a year of their own money on lotteries, partly because they think the likelihood of winning is much larger than it actually is. But instead of using this to take advantage of people, you can use similar approaches in terms of trying to improve engagement and health improvement programs, and I'll give you some examples of how we've done that. We also know people are very aversive to regret. They're very loss averse. These are both very important principles that can be built into program design, and people have what's called a very strong status quo bias, meaning that they will tend to choose the default, the path of least resistance, and that can be very useful as well in terms of helping people improve their health. So this is a very famous example that was published by Eric Johnson, who's at Columbia, and Noah Goldstein in Science a number of years ago. And it's a simple description of the rate at which people sign up for organ donor registries in different Western European countries. They made the observation that the countries in left, in yellow, are all countries which have an opt-in for organ donation. The countries in the right in gray are all countries that have an opt-out. And you can see that the difference here in sign-up rates are enormous. The key difference, of course, is that the countries in the left, you have to actually decide to join and opt in. The countries on the right, you're presumed to be in unless you explicitly opt out. And this really opened a lot of people's eyes because it's hard to imagine too many interventions where you can have an effect size this large. One of the questions it raised, though, is whether people really recognize they could opt out, because when you have a percentage that's very close to 100%, it raises the question of whether it felt to people more like a mandate as opposed to a default. My colleague Scott Halpern recently led a study which looked at this in a very different kind of setting, where the recognition was that in terms of end-of-life care, as we know, care often tends to be overly aggressive. And what he did is he randomized people with terminal diseases of the chest, such as metastatic lung cancer, to 3 different types of advanced directives: a comfort-oriented plan of care, a standard advance directive in which the provider or patient's family could later choose, or a life extension default. And it was very interesting what he found. 77% of the time, people randomized the comfort-oriented plan of care, in fact, chose a comfort-oriented plan of care. 43% of the time, those randomized to a life extension default actually overrode that and chose a comfort-oriented plan of care. And part of the reason why this study was conducted was really to see, in high-stakes decisions like this, do defaults actually work? Because you could imagine people would have very strongly held preferences. And I think what this highlights, if you think about all the conversations that happen each day between clinicians and patients in hospitals around the US, is that people do respond to the suggestive power of how a clinician frames a decision. And if the clinician frames it a certain way, people will choose that choice at very high rates, even in a very high stakes area like this. Here's another example of how you can think about defaults. There are lots of opportunities with the proliferation of electronic medical records to think about how we improve value in healthcare. And this was some work led by one of our former fellows, Mitesh Patel, where he looked at generic prescribing rates across our health system being the Penn Health System, and looked at the impact of changing to an opt-out default. You can see these generic prescribing rates are all over the map. This is a nice example where you can imagine we can improve value without any appreciable downside because generics tend to be equivalent to brands. Since they're cheaper, people actually take them at higher rates, so there's some evidence that people who are prescribed generics actually do better in terms of their health because adherence rates are higher. And here's what he found. Pretty instantaneously, the rate of generic prescribing went to 100%, with one notable exception, which is important, which is Synthroid is the exception. And Synthroid is well known among clinicians to the generic forms tend to have variable rates of absorption. And so it was very important that clinicians were able to appreciate here that these are not equivalent. And in the case of somebody with well-controlled thyroid disease, keeping them on the brand made sense. There's also cases, though, where it's not as simple as thinking about putting a default in place, opt-out default, and then assuming everything will take care of itself. This is some work we did with CVS where the underlying problem was they had designed an automatic refill program for people on lots of medications, and they had hoped that people would sign up for this in droves because it would be obvious that it'd be more convenient if you're on 10 prescriptions to have the prescriptions arrive by themselves every 90 days as opposed to having to remember each time to reorder the refills. And what they found was they had set it up as an opt-in program, and the rates at which people signed up were much lower than they had hoped. So they asked us what they might do about it. The obvious first question was, could you do this as an opt-out default? And they said, no, we can't. Every time one of these prescriptions goes out, we have to charge people's credit cards. People are going to be very upset with those charges if they haven't explicitly authorized them. So what we did is we embedded within the refill process an active choice, simply an opportunity for people to decide, yes, I want to do this, no, I don't. And we further enhanced that by highlighting some of the salient aspects in terms of convenience in signing up for the program. So on the bottom left, press 1 if you prefer to refill your prescriptions by yourself each time. Press 2 if you'd prefer for us to do it for you automatically. So you can think about this as a fairly gentle nudge. It more than doubled the rate at which people signed up for the program. CVS now uses this pretty widely throughout their business. And I think the nice feature about it is it reflects a choice people actually made to participate as opposed to something they were defaulted into. And for activities that require ongoing engagement, that's probably pretty important. So moving to incentives, there's, all of us are part of, I hope, a health insurance plan. And a health insurance plan, in essence, is like a giant incentive plan that is trying to steer you to use more or less of different kinds of healthcare services. But unfortunately, a lot of these plans are very complicated. And this is an example of one such plan where there's 20 to 25 pages like this of small print. And in essence, what we and others have found is that plan designs are way too complicated. I probably didn't need to tell any of you that. But there's a veritable alphabet soup of different financial levers that are being put in play, often simultaneously, to try to influence utilization. And patients typically don't understand many of these aspects of plan design. So for example, coinsurance and deductibles, people really struggle with. When people are asked to try to calculate how much an episode of care would cost, we found people are only able to do it about 11% of the time. And so the challenge here is that we're putting in place all these plans and we're hoping to use them to guide choices, but people by and large don't really understand the provisions that are really intended to influence what we choose. So one of the interesting opportunities we had was to do some examination of what people understood and what people didn't, and then work with Humana to design a new plan called Humana Simplicity. And this was a really fun exercise because in essence what we found was that the one element of plan design people did understand pretty well were copayments. And we designed a plan that was copayments only. You can think about a copayment as being very analogous to you walk into a store, you pay a price for a good or service. There's no fancy calculation involved. And this is now launched. I think there's about 50 to 60,000 people who have signed up. So we're very interested to see how this goes forward, because it really has two interesting features. One is that it's copayment only. The other is that the plan description is very simple and fits on between 1 to 2 pages. We've also done a lot of work in trying to think about how do you build incentives that can actually change people's behavior in the context of employers, large employers within the US. And what we did here was to try to take on the problem of smoking. As I mentioned at the outset, as we know, smoking is a huge public health problem. But employers are well situated to try to influence this because they have a lot of channels they can use, including their benefit designs, to try to influence the behavior of their employees. And in essence, the problem is that about 70% of smokers in the US say they want to quit. About 3% per year are actually able to. And it's a sort of a classic procrastination problem where even if a lot of people want to quit smoking, the immediate costs in trying to do that always loom very large because it's very difficult to quit smoking, but the benefits are very distant in time. So it's very natural for a smoker to think, yes, I want to quit, and I'm going to plan to do it next week because this week the costs, in essence, outweigh the discounted benefits. Unfortunately, next week it will be easy to come to the same conclusion. So what we were trying to do here was make it more attractive to people to quit smoking in the short term. We randomized people who were employees at GE to either information about smoking cessation benefits programs near their workplace, or that same information plus a package of incentives worth $750. And in essence, what we found was we were able to roughly triple smoking cessation rates from about 5% to 14.7%. Based on that, GE implemented a program for all their employees in the US in 2010. More recently, we've been working, and this is work led by my colleague Scott Halpern, on trying to think about how do we bring the concepts of pre-commitment and deposit contracts into this space. And I mentioned earlier on that people tend to be very loss averse. So we know that people respond very well when there's a chance they'll lose money. They will work very hard not to lose that money. And in essence, what we wanted to see here, building on the GE example, was if we gave people an opportunity to put their own money at risk, which they would lose if they were not successful in quitting smoking, but which we would quadruple if they were successful in quitting smoking, was that actually more effective than simply offering to people an equivalent amount of money? Because in essence, what you see as you think about concepts like these pre-commitment or deposit contracts is that effectiveness within the population is really a combination of acceptance and efficacy, where the interventions both need to be acceptable and then efficacious among those who accept them. And what we found was interesting. In essence, for populations, so this was, I should mention, it was a study of about 2,500 employees of CVS. We randomized people to 5 arms, information about programs, a similar reward structure to what we used at GE, where you would just get money if you met certain milestones, and that was confirmed biochemically as having quit smoking. We also had group rewards that were of similar value, and then we also gave people the opportunity, as I mentioned, to put their own money at risk, which they would forfeit if they weren't successful, but which we would match generously if they were. So the first comparison to look at is between the yellow lines and the purple lines, where you can see that we in essence replicated what we found at GE, nearly a tripling of smoking cessation rates at 6 months and similar findings at 12 months. However, when you look at the green bar, which is the deposit arm, you see that this group actually did worse than the standard reward arm. And this at first was a little bit of a surprise. But when we looked at unpacking this, what we found was interesting. So among people offered a standard reward, you can see almost everybody accepts this. There's really no reason you wouldn't accept it because you only have a chance to win money. There's no potential downside. And among those people, we had 17% quit. Among people offered the opportunity to put their own money at risk, we have much lower acceptance rates, 13.7%. Among those people, we see very high quit rates, 52%, but when you multiply this all out, you end up with a lower quit rate than just offering people a standard gain-based reward. We tried to estimate, all else being equal, for people who are willing to put money down, what the quit rate would be, and we think it would be higher among people who are willing to put deposits down. And one of the exciting things about this was that we worked very closely with CVS on trying to think about what does this mean for program design in practice. And coincident with the publication of that study in the New England Journal of Medicine a few weeks ago, CVS issued a press release announcing a new program called 700 Good Reasons to Quit. And the program, in essence, took the findings from the research and in a much faster way than I've ever been part of, translated them into practice, where they asked us, what should we do? What should we do about the fact that it appears the deposit works really well for people who do it, but most people don't do it? So what we did is we lowered the deposit amount to $50. We increased the match amount to $700. So in essence, it's a 14-to-1 match. And the idea is to make it irresistibly attractive to people who are smokers to do this and participate. And then the hope, of course, is that they will be very successful once they're in the mix and they don't want to lose this opportunity to get the 14-to-1 match. So CVS launched this nationwide for all their employees in the US June 1st. And we'll be very interested to see how this goes, both in terms of acceptance rates and, more importantly, quit rates among their population. We've also done a lot of work with other kinds of concepts, and this is an example of some work we've done on weight loss. We've had a number of studies we've done on weight loss, and this is just an example I wanted to share with you, where, in essence, we've tried to take some of these same principles and think about how to design them in such a way that really lend themselves to trying to help people lose weight. In this case, we randomized people to either a daily lottery or a deposit contract where they'd put their own money at risk. They'd forfeit if they weren't successful. We'd double it if they were. And what we found here was that both the lotteries and deposit contracts were much more successful in helping people reach their goals. About 50% of people reached a goal weight loss of 1 pound a week compared to about 10% in the control group. Social incentives are another very promising area. This is some work that my colleague Judith Long led, where we randomized people with poorly controlled diabetes to a peer mentoring system versus an incentive. And what I think was interesting about the peer mentoring system is, in essence, she took people who used to have poor control of diabetes and now have good control and paired them with people who still have poor control and just created a mechanism for social altruism to work and for people to help each other. And in this case, it was more effective than the incentive itself. So part of why this is important is from a public policy standpoint, one of the provisions of the Affordable Care Act, Section 2705, allows employers in the U.S. now to provide up to 30 to 50% of health insurance premiums as penalties or rewards based on smoking status, body mass index, blood pressure, cholesterol. It can be up to 50% if they include smoking, up to 30% if not. And our concern is a lot of these programs, as they're being implemented, it comes back to the points I was making earlier about standard economics. A lot of employers are assuming, let's just adjust premiums and everything else will take care of itself. And we're pretty sure that that's not going to have the impact that a lot of public health people would like. But there are a lot of other approaches that could be used here that I think really tie into the underlying behavioral principles and would make these programs more effective at improving health. So I want to conclude by just talking a little bit about the implications of all of this in terms of chronic disease management. And I mentioned the shifts in health financing that I think are going to propel much greater interest in the healthcare provider community and trying to figure out how to keep people healthy as opposed to treating them when they get sick. But the underlying challenge here is that if you're a patient with chronic disease, even multiple chronic diseases, and you see a doctor 20 times a year, each of those visits might have 10 minutes of face time. So you have 3 or 4 hours a year in front of a doctor, 5,000 plus waking hours where you're on your own. And doctors tend not to have tools to help you improve your health behavior. They don't really know what you're doing and don't really have good ways to help you. So the key thing here is that the proliferation of wireless devices really creates enormous opportunities to think about how chronic diseases might be managed in the future, really leveraging the advances in technology, but I think also very importantly, tying into advances in behavioral science to figure out how do we take the high risk, not all that engaged patient and help them get more engaged in their health in a way that will be likely to reduce their future risk. The way we've thought about this at Penn is with a program we've developed with support from the National Institute of Aging we call the Way to Health. And in essence, what we do is we take wireless devices of various kinds, and the only key characteristic here is we try to find devices which can passively upload data because that's really essential in terms of long-term engagement. These could be scales, blood pressure cuffs, glucometers, Fitbit pedometers, medication adherence monitors. They upload data to a server, and then depending on what sort of research program people are in, the device will push back information to people either by text, by email, by interactive voice recording. It can go to the patient, him or herself, to a social supporter, it can be a friend or family member, it can go to a peer mentor through an exception handling process, can go to a clinician. And then for people who are in financial incentive programs, we can transfer funds to people electronically. And I want to highlight two things about this. One is that scale is really impossible without technology. But on the other hand, technology is useless if it doesn't modify behavior. And many of the high-risk patients for whom this would make the most economic sense at baseline aren't very engaged. So we really have to think about how do we bring together an understanding of behavior, the new possibilities created by technology to really drive scalable behavior change. So this is what this looks like under the hood. And I'm not going to go through the complexity of this other than to say it's complex under the hood, but what the end user, what the patient sees is really just that glow cap on the top left, and then various push vehicles we use to communicate with them. I also want to highlight to you, though, that the technology itself really creates enormous opportunities, but as I mentioned, by itself, it's not sufficient. So this is an example of a study we did among patients with poorly controlled diabetes. We gave them free wireless glucometers, blood pressure cuffs, just asked them to use them every day, and your doctor's office is going to help manage your blood sugar and blood pressure. And what you see over time is that in the control group that's just asked to do this every day, there's a steady attrition in terms of the rate at which people do it. It's about 50% of the time after 3 months, about 30% of the time after 6 months. But the two groups that were given different kinds of daily lotteries did this 80 to 85% of the time, and that was associated with better glycemic control because then we had a feedback loop that could work. Here's another example of how we're doing this. This is with support from CMS through the Innovation Center, and it's really addressing the issue of medication adherence after heart attacks, where we know that despite lots and lots of good clinical trial data on the efficacy of cardiovascular medicines in reducing morbidity and mortality, adherence rates for patients after a heart attack are incredibly poor. Even among insured patients, they tend to be about 40 to 45% in the first year following a heart attack. And in essence, what CMS wanted us to do here is to really take on the challenge of achieving the triple aim, in particular improving health outcomes and trying to reduce costs. And so they asked us, in essence, to put together these types of compound interventions. These are not as scientifically parsimonious as what we would probably be inclined to send to NIH, but we're basically parceling together a group of different interventions here, each of which has some supporting evidence to try to come up with a compound intervention that we think will be more effective. And we give all patients who have had heart attacks wireless pill bottles for their cardiovascular medicines, daily lottery type incentives, a social incentive in which each friend or family member they identify gets notified if they miss 2 doses of any of their cardiovascular medicines. If they miss 4 doses, we have a clinical social worker call the patient, call the friend or family member, and in essence creates an early warning system that we hope will be much more effective at catching people before they get sick and have to go back to the hospital. And this is being done in partnership with Aetna, Humana, a couple of the Blues plans, Health First, and CMS. We have 1,500 participants in 45 states and the District of Columbia. And so far, the data looks very promising. I mentioned to you the standard adherence in this realm is about 45% among insured patients. And so far, we're seeing adherence rates of about 80, 85%. So we're very encouraged by that. We won't know what the impact is yet on hospitalization rates, procedure rates, until we look at the claims data, and we're waiting to do that, of course, until we're done with the trial. So we have a lot of different studies in the field, many of which are being supported by NIH, trying to figure out how do we take these concepts of using wireless devices and behavioral economics to improve health, both in the context of smoking cessation, weight loss, improving the capabilities of medical homes, and I think very importantly in the context of medication adherence, because that's often a final common pathway for chronic disease management where we think these types of approaches could be very helpful. But in essence, this is where we think things are going. So if we look back to 2014, much of care delivery within the US is embedded within a reactive visit-based model of delivering treatments. Healthcare financing has been based predominantly on fee-for-service, and providers have relatively little data to guide decision-making outside of their offices. The limited telemonitoring that exists consists of giving patients devices and hoping they'll use them. And where we think things are heading, and a lot of this may happen fairly quickly, is to a model that is much more proactive and which relies much less on seeing people in doctors' offices as opposed to addressing their needs remotely. And how fast this will happen, a lot of it really depends on how health financing shifts in terms of bearing risk for populations and how quickly that happens. But as it happens, we expect that there'll be a lot of use of various kinds of wireless devices that will be used to give automated feedback both to patients and to their providers, and where we think these types of behavioral economic strategies are going to be very important because the health and economic opportunity often rests in those patients who are not doing that well under the current system. So with that, let me thank you again. I'm very, very honored to have a chance to be here today, and thank you again for all of your support.
So I think we could take a few questions now if anyone has any.
Yes.
Very interesting talk. It strikes me that a lot of what you're describing are behavioral change interventions as opposed to behavioral maintenance. So what happens over long term, especially when people, the incentives or the structures that are created are removed, is there anything that internalizes the behavior so it continues?
We've typically found in the smoking studies that the rate of maintenance is pretty good. And I think a lot of that is reinforced by a lot of the changes that have happened in built environments that reinforce the decision to remain a non-smoker. Weight loss has been much tougher. We find typically that once we discontinue the incentives interventions, people's weights return towards baseline. We have a couple of studies that we're doing now with support from NIA that are geared towards working on maintenance of weight loss among people who had initial success in losing weight and looking at a couple of different approaches to doing that. One of the interesting questions with the Affordable Care Act in Section 2705, which is that provision that increases the amount of premiums that can be used towards penalties or rewards, is whether some of these goalposts have shifted. We've always thought about the goal of trying to have a time-limited intervention that had sustained effects. But increasingly what we're seeing in the employer benefits space is that these programs are being put in place with the expectation that they'll continue. And so it's an interesting shift in thinking about what the goals of the program should be and what the optimal design might look like. John?
Do you have any regularities that you've observed across studies in what types of people these tricks work best with? Old, young, educated, non-educated. You remember the famous saying that Jabba the Hutt said that your Jedi mind tricks don't work with me.
Well, it's interesting you ask that because we've started to look much more at this. Within each individual study, we tend not to be powered to really be able to look at these subgroups, but we've started pooling data across a lot of studies to try to better understand this. I think generally speaking, what we see is that lower income people respond more. There's also the suggestion that lower income people may respond better to lotteries in particular. But we're still trying to understand this both in terms of observable sociodemographic characteristics and various types of behavioral phenotypes to try to understand what kind of programs work better and what kind of people.
Can I ask you to use the mic? We actually have them.
Yeah, the follow-up question to this one, which is behaviorists, variable ratio is the reward schedule from mice to humans that gets the most persistence. And that's what I was thinking, exactly what you're saying. Even not just even lotteries as much as, it's a lottery in some ways, but literally varying the incentive and having it be a true random occurrence, or you could even game the system, as economists sometimes are known to do, and manipulating the effects. But, and again, some of the things in terms of how you engage some of the harder to reach groups, it pretty much works for everybody. It's just a matter of getting them to the tables.
Yeah, no, I think that's largely true. The important questions that remain are around how to optimize that, and then thinking about the cost effectiveness of different approaches in different settings. Another interesting element, which I think is going to be very important, is the question of how dynamic to make these rewards, because you can vary, obviously, the probability, you can vary the magnitude, you can vary all of these things over time. And related to the first question, a very important issue is going to be what produces the best sustained effects. And that's something which I think we're going to need to figure out.
I think one more question and then we'll move on.
Good afternoon, Neil Wasserman from Time Wave Analytics. I'm a big fan of your work. Let me just venture to suggest the next stage in the evolution that you described at the beginning of your talk. And that has to do with moving from what I would refer to as simple adherence to general adherence. Simple adherence being adherence to a single behavior, and general adherence being adherence to the complex set of behaviors that might be required for a chronic condition like diabetes or multiple chronic conditions. And the challenge is that the simple behavior models don't scale very well. They don't scale very well in time. That is, they don't necessarily persist, and they don't scale to multiple chronic conditions that might involve thousands of activities over the course of a year. So I'm just going to, I have some ideas on the subject, but I'll ask you to speculate on how we move toward the more general view of chronic disease management using these kinds of techniques.
Yeah. Well, it's a very important question because as you're reflecting, I think a lot of the interventions that have been developed and tested tend to focus on a specific behavior, a specific disease, and really what we probably should be doing is focusing on specific people and all the risks that they have. And that, of course, in some ways it's simpler, but in many ways it's more complicated because a lot of the programs that have evolved really are centered around somebody's weight. And I think what we need to move towards is really thinking about how do we identify the people who will be benefited most from a particular set of interventions, and then really think about in some logical fashion, perhaps through a step therapy type approach, how do we escalate the kind of behavioral interventions we offer them in such a way that it's both cost-effective and potentially scalable, because there are a lot of people who have a lot of different risks, and I think a big limitation is that many of the programs really just address one of those risks and basically ignore the fact that the person has lots of other risk factors that haven't been addressed.
Thank you very much.
Thank you.
Now, if I could ask Dr. Jeannie Brooks-Gunn to come up and we'll listen to her lecture.
Thanks, Erica. Out of range. Oh, video, we don't care about that. I'm so pleased to be here, and I'm so pleased to be a recipient of this award. I was lucky enough to know Matilda Riley, unlike Kevin, and there are three things that she really, I think, influenced me on. The first is, of course, she was a woman who did her research and moved to different organizations, continued on her path at what she thought was important. The second is that she gave back to science, and that's what she did here when she came to NIH. And that is when I knew her at that point. And I think that's something, I'm a life course developmental psychologist, so I think about life course, and that's something all of us can think about. You know, there are other ways to contribute to science besides being a scientist. And the third is she came to NIH when she was my age. So I've thought a lot about that and what my next 20 years bring. Again, I am a lifespan developmental psychologist. So I'm just so pleased to have gotten this award. What I'm going to do is give a whirlwind view through some of the developmental research that I do. And I've entitled this The Long Reach of Early Childhood. And I want to talk about biological and environmental influences. It's really unbelievable to me, being a life course person, how rapidly, in looking at the life course, biology and actual measures of biology have been brought into the research that we do. So I'm really lucky to be doing research at this time when all these things have been brought in. In the olden days, we talked about the temperament of the child, and we did that by asking questions about a child's temperament. Now we have biological measures. So the world has changed so fantastically, and I'm so glad that I happen to be doing research at this time. What I look at, what I'm interested in, are well-being and disparities in well-being. When we look at childhood, I'm looking at cognition and schooling, behavioral regulation, and physical health. We are interested in adulthood outcomes. So, of course, the three that are related to the first three are earnings and education, crime and mental health, morbidity and mortality. I'm particularly interested in the first 8 years of life, and I'm interested in the fact that we see huge disparities in how children are faring by age 3, 4, and 5. I'm not going to show you a lot of data on this, but the differences between poor and non-poor children are very striking. And in fact, the disparities as a function of social class are now larger than the disparities you see at age 5 by race. So I think I'm very concerned about racial disparities as well, but it's important to realize that socioeconomic status in terms of how kids enter school and what's happening to kids over their life phase, at the moment, social class is trumping race. Quite remarkable. I look at childhood adversities in capital, and I look at low family income, low parental education, and I also look at economic conditions. We've done some work on the Great Recession. I'm going to present a couple slides on that. You guys can read what we look at, people like me, in terms of low family income. Typically, we're talking about poverty in the bottom quartile of the income distribution, and then near poor, it actually should be quintile, is the second to bottom quintile of the income distribution. What we really are finding today in general is that if we're worried about income, we really are talking about income for the bottom 40%. I'm not talking about 5%. What you're really seeing is that there is the bottom 40% are being left behind. This is in terms of cognitive disparities and academic disparities. And the top 20% are taking off. We have bigger disparities today than we did 40 years ago. I look at family life adversities, and I've just listed some of these here that people like me look at. We look at harsh and disengaged parenting. We look at the emotional health of parents. Think primarily of anxiety and depression. We think about cognitive stimulating experiences. I'm thinking more and more about violence that children are experiencing or witnessing in their lives, and also what I call household turbulence, which really has to do with conflict, frequent moving, moving in and out of households, and what some people would just call chaos. The best measure of chaos that I've ever heard is and all of us probably have felt this, there's so much going on, I can't think. That's my measure of chaos for myself. I also look at neighborhood. I'm not going to talk about neighborhood today, but I've done a lot of research on neighborhood, and I just wanted to list some of the aspects of neighborhoods that people like me look at, trying to understand how children fare in the world. And these are some of them. We can talk about them later. There are 2 or 3 models that have basically propelled the research and the interventions that have been done with young children. The first is the human capital model. Here you're looking at low income and low maternal, primarily education. And you're looking at how these relate to talking, reacting, and being sensitive to children, and the provision of stimulating materials. All of these are believed to influence achievement. These are the kinds of measures I would look at to make the point that I can show differences as a function of social class, income, and education on 3-year-olds' cognitive functioning, and actually probably 2-year-olds as well. They tend to be through these 3 pathways. Here's just one example. You've probably heard Hillary Clinton talk about the 30 million word gap. She is doing a lot on what she calls too small to fail. I think it's a great title. But here's the data she's basing that on. This is a study where audio tapes were taken in homes of a very small number of kids. And people have looked at the cumulative vocabulary, what kids would hear over time, and you can see the differences by education here. Family stress model is the second model that people like me look at. Here we're typically looking at low income, not low parental education. And the 2 pathways through which this works would be parental depression and anxiety, as well as harsh parenting. Here the outcome typically is behavioral dysregulation, think aggression, think attention disorders, things that are related to school achievement. In our work, we're bringing more family adversities into our models. This just shows some of the ones that we would put in. These tend to operate by affecting parenting, specifically harsh parenting, which then would be related to mental health. And think, again, aggression, attention, and perhaps anxiety, what I call the 3 A's. Now, for people like me who try to study childhood adversity and what happens to children, there are just a few ways that we think about this in terms of theory and ways of testing our models. The first is to really understand our upstream correlates and conditions. The second has to do with continuity and timing, and this is the hardest one, and this really is related to when we decide to intervene with kids. The problem is people often say early childhood is very important, which I believe is true. The problem is that if a family is poor in the first 3 to 4 years, they are probably poor in the next series of years as well. This is also true for harsh parenting. If I have a parent who's being harsh very early, very likely that parent continues to be harsh. So can I separate out when it occurs from the continuity? And that's really important if you're trying to figure out when to intervene and what you want to intervene on, besides being important theoretically. We also look at reciprocal effects. People like me have thought a lot about, is there a heightened salience to certain childhood adversities at various ages? This kind of goes back to the timing issue, but it's very important. A lot of work has been done on puberty, not on the first 5 years of life, suggesting puberty may be a time where children, youth, are particularly influenced by negative conditions. We consider cumulative risk, co-occurrence of risk, and then I look at biological processes as markers and as moderators. I'm going to present some data from Fragile Families talking about all of these issues. This study, funded by NICHD, is a birth cohort that's been followed through age 9, and we are in the field at 15 as we speak. We have 20 U.S. cities, almost 5,000 families, 75 hospitals. We oversampled non-marital births because non-marital births we consider fragile families, hence the title. This study will probably never be replicated because we had to get IRB, separate and different IRB approval from each hospital, which was a nightmare. This study is representative when you weight it up for the demographers and epidemiologists in the room to cities with populations of 200,000 or more. This is the timeline when we were in the field, and as I said, these are the times we saw our families. Unlike any other study that's been done, we interviewed the mothers and the fathers at all of these ages. How did we get the fathers? It's really hard to get fathers in studies. We got them when they were at the hospital. So our baseline was done at the hospital. Whether you're married or not and you're a father, you go to the hospital in most cases to see the baby. So we have the best data, actually, probably internationally, on fathers' contribution to children. We ask a lot of different things. We talk to the child, we talk to the mother, we talk to the father, we go into the home, and we collected DNA data at age 9 and are collecting it at age 15. Why did we look at unmarried women? Because we have lots of births to unmarried mothers. It's over 40% for the total sample right now. For births to women under 30, it is over 50%. There are racial disparities, but it's high for all groups. And this was my point earlier that things have changed over time. If we look at low, middle, and high education and the percentage of unmarried mothers, you can see that it's really skyrocketed for the low education group. Unmarried motherhood is still relatively uncommon for high education mothers. From our sample, 50% of our unmarried parents were cohabiting at the time of the birth. Only 9% had little or no contact with the children, which I think the fathers having little or no contact. The unmarried fathers' capabilities at birth were vastly different from married parents. You guys know this from the media, but there are a few things that I think are important here. Poverty is hugely different. The education is totally different. And what's very important and shocking to me, even running this study, is that our unmarried fathers are more likely to have been incarcerated. In our sample, it's 40% have been incarcerated by the time the babies were age 9. That's a lot of incarceration. And again, I personally was shocked by this number. I would have predicted if, I don't know if you guys do this in your teams, but we have bets and then people have to buy, wine and dinner. When you lose the bet. Oh, it's really a fun way to do research. Anyway, I would have predicted 15% would have been incarcerated. I would have been really wrong. The sample in terms of ethnicity, it's about 40% Hispanic, 35%, 30% Black, and the rest are white, very few Asians. What's the story about turbulence? The story is that these unmarried families, the kids, think now you're the child being born into this family, you're very likely to have your parents break up by the time that you are 5 years of age. This, for some reason, is all messed up, but just ignore the fact that it's messed up. I don't know why it's messed up. But what you see there is about 60% of the unmarried births, the parents had broken up by the time the kids were 5. This just gives a little example of the number of transitions that have occurred. Just look at the unmarried mothers. I think that's the most important. We're thinking, again, of the number of transitions that these kids have experienced by age 5. And what you see is a huge, huge number of transitions for the unmarried mothers or the kids by the time the kids are 5. So what you're seeing is not just are they unmarried, but basically fathers are moving in and out of the house. And so what you see is a lot of turbulence. And one question we have is it the turbulence or is it being unmarried that makes a difference, right? Because people have always said it was being unmarried. It could be the instability in the family. Here what we've done is just put together the family type and the instability. And you can see that you have complex families and unstable. This is going through age 5 again, about 77%, very high. By age 5, our unmarried kids to unmarried kids have lower scores on cognitive tests, more mental health problems, more physical health problems, specifically asthma and obesity. And this is net of all the differences in resources at birth. This is controlling for everything that we can control for. We do find that the more instability, the more likely that there are problems for our children. I want to turn briefly to talk about harsh parenting for a moment, because that's a family adversity that we've done a lot of work on. This is looking at the percentage of children who had harsh parenting at different ages. Any spanking, that would be 40% for the first white bar at 1 year of age were spanked. That's a pretty high percentage of kids that are spanked. And notice by 3 to 5, it goes up to 65 to 70% of all these kids have been spanked. We also were interested in high-frequency spanking. That's less likely, but you can see that it's about 10%. And then it goes down by age 9 years. There are lots of correlates of harsh parenting, which I won't go into here, but they're the ones that you would expect. Boys are more likely to have harsh parenting, parents who are stressed, smoking and drinking during pregnancy, prenatal violence toward the mother, late prenatal care. Again, I don't think this is particularly surprising. Here, what we've done is looked at cumulative risks, going back to some of the risks that are listed here. And what we're doing is looking at externalizing problems. And you are looking at kids with low, medium, and high cumulative risk. And what isn't shown here, which I don't understand because it was, but that's life. Here you're looking at kids who were spanked at 3 waves of the data. These are kids who were never spanked, but they had cumulative risks. And then these are kids that were spanked in 1 to 2 of the waves. What you find is that for the kids who were spanked 3 or more times and had high cumulative risk scores, their mean externalizing scores were about 20. 20 means that they're in the clinical range of aggression. They're incredibly high. I've never seen a mean score that high in any of the work I've ever done looking at aggression. And I think this is really important. I'm going to skip that. We also have looked, when we look at the low spanking, high spanking, cumulative risk, not cumulative risk, by the genetic alleles that the children have. And what we have here is a dopamine allele on the DRD2 gene. And what I want you to look at here is the early harsh parenting kids that had high cumulative risk. If those kids had what we call the sensitive allele from this dopamine gene, again, their scores are almost 17. So what you see here is a beautiful 3-way interaction, looking at early harsh parenting, cumulative risk, and then looking at genotype to understand that some kids are more sensitive to this harsh parenting than are others. And this is the kind of work that, again, in the past we would have looked at temperamental differences, But now we are able to actually look at genetic sensitivity. Okay, is that clear? We've done quite a bit of work. I'm only presenting 3 examples of some of our gene by environment interaction. I like this one particularly because it is a 3-way interaction, and it is looking at early harsh parenting, since I'm so interested in the issues of timing. My next example from biology is telomeres as a marker of stress. In our 9-year-olds, we have analyzed the telomere data, and I'm going to talk about telomere length here for a few minutes. This is what we have done. The first paper that we published off of our telomere length data came out in PNAS. It is only on 40 boys. They were African American boys who are 9 years of age. That's when we collected the telomere data. The shortening of telomere is considered by many to be a marker of stress. There's a very interesting issue about whether you can reverse this, if telomeres can be lengthened. I think the jury is still out on that. Interestingly, Richard Sussman before he passed away, had put together a reversibility network. I am part of that, which is asking those questions. Can you actually put interventions in place that can reverse some of the damage that's been done? And one thing we will be looking at is telomere length between age 9 and age 15, because we'll have the data at age 15. What we found in this, we looked at 4 different harsh family conditions, which I'm going to show you in a minute. What we found is telomere length was shorter for the boys in the harsh family conditions, which is probably not so surprising, except we only had 40 kids, which is not that many kids. It also turns out it is shorter for the boys in the harsh family conditions if they had the sensitive alleles for dopamine and serotonin present. So what you got here, which I don't think anyone else has shown, is an interaction predicting telomere length is now the outcome measure. I'll just show you, we had 4 different variables that we put in our harsh environment measure: mom's education, family structure, my harsh parenting index, which did nothing here. That was very upsetting to me, but that was 40 kids. We'll see. Now we have the data on 2,000 kids, so we're about to do more data. And then average income to needs. Everything worked the way you would have expected, that these negative events were related to shorter telomere length. This is the interaction that I found so interesting. We've looked really at serotonin and dopamine somewhat separately. We've looked at advantaged and disadvantaged kids, dividing them into 2 groups, again, of only 20 each, and then looked at how many sensitive gene alleles they had in the serotonin system that we were looking at and the dopamine systems that we were looking at. And what you're seeing here is some evidence that when you have sensitive genes and you are more disadvantaged, you have lower telomere length. Look at the up. And what's also interesting is there's a little hint that if you are in an advantaged environment and you have the sensitizing genotypes or gene alleles, you actually have longer telomere length. So people have been talking a lot about genetic differential sensitivity, which would suggest that kids with particular sensitive gene allele patterns will do worse in bad environments, but better in good environments. This is just a little example of that, and we will be looking at that more. We also have just finished some analyses because we have a bigger sample now, with children from Latina mothers. 2/3 of these moms were born in the United States and 1/3 were not. And we're really interested in the immigrant health advantage that people have been talking about with other measures, not telomere. And here what we're finding is native-born mother kid, these are the 9-year-old kids, right? But of the native-born mother had the shortest telomere length. The mothers who came to this country prior to the child's birth had longer telomere lengths, and it didn't matter when the mother came. We controlled for about 50 different variables, so I think this is true. This is probably the first example of, if you will, the immigrant advantage, but using a measure, a biological measure like telomere length. Typically, people have looked at other kinds of measures to suggest there is an immigrant advantage. My next example really has to do with parenting and related to the Great Recession. We're still, I should say, trying to understand what is different in the lives of the kids whose mothers were native-born and the kids who weren't, especially given that we controlled for 50 different things. There has to be something going on. Of course, it could be prenatal, it could be food, it could be breastfeeding, but we controlled for all that, but we're still trying to understand what's going on. Let me turn to the Depression. What we have, Great Recession, sorry, it wasn't a depression, except it really was. We happened to be in the field at age 9 when the Great Recession happened. What I've done here is the red bars show you when we were in the field, okay? And then we have 3 measures of the Great Recession that we have up there. I'm going to tell you what the CSI is in a moment. You see that peaks during January. If you remember, that's when Bear Stearns and people went under, and people were worried that fall, what was going to happen to our whole economic system. Then I've also put unemployment rate and foreclosure rate, so you can see how those work. What you do see is that the CSI, which is a consumer confidence measure, actually kind of relates to Kevin's work in terms of people's uncertainty about the future. It actually is very useful from a behavioral economics measure. It leads unemployment rate by about 3 to 6 months. And then you notice the concern about the economic uncertainty dropped even while our unemployment rate continued to go up. So our group has been really interested in understanding what happens during a recession or depression in terms of parenting and child outcomes. I'm not going to present child outcome data. This is this consumer sentiment measure, because you guys probably don't know what this is. It's collected every month by a telephone survey. It asks about economic uncertainty in the world as well as in your own life, okay? It's normalized to have a value of 100. We reverse coded it, so a high CSI is bad. It means there's a lot of uncertainty. Given that we were in the field all this time, we are able to attach to when each mother and child were interviewed at age 9, the actual CSI rate, unemployment rate, and foreclosure rate at the time of being interviewed. Got it? Right, because we were seeing people all during that. Then we use a lot of fixed effects models and controls for cities. Our cities differed in terms of the unemployment rate. Detroit was in our sample. It obviously, the unemployment rate was much higher for Detroit than some of our other cities, but we control for all of that, of course. It is important that the CSI is national. I can't do that at the city level because they don't ask enough people. But it's a really interesting measure. And just to cut to the chase, we're looking at high rates of spanking and risk for child maltreatment. Remember, the CSI goes up. That means economic uncertainty and concern is higher. And what you see is an increase in severe spanking as the CSI got worse. We found this even controlling for what the mothers were doing at age 5, which makes it even stronger finding. And we also controlled for the unemployment rate. It wasn't the unemployment rate, it was economic uncertainty. We've also controlled for whether the mother herself was unemployed or the father, and it wasn't that. So when people are uncertain, and again, I don't think anyone has shown this before, people have more harsh parenting. Now, it also turns out they spend more time with their kids. So you can't decide, are they doing more harsh parenting because they're spending more time with their kids? You can make a lot of arguments. But what I want to show you for the biological piece of what we did, we also here we're looking at dopamine, and we were looking at whether or not mothers, this is mother's genetic sensitivity, not the child's, whether the mothers who had the sensitive alleles on, in this case DRD2, showed more of an effect as a function of the recession. And what you see here is that our mothers with the more sensitive alleles were the ones who showed the big uptick, right, at the time of the very beginning of the Great Recession, when you saw the CSI take off through the roof. So here's another example of a biological by environmental interaction. A lot of economists like this finding because the environment is, if you will, exogenous to the family itself, i.e. the family did not cause the Great Recession, and you can't say that the causality is reversed. So this article came out in PNAS about 2 years ago, and as an example, again, of the kind of work we're trying to do, putting together biology and environment in the Fragile Families study. We actually found effects on kids too, but just to let you know, there were effects of the CSI on children, but only on the boys. And we got that in terms of the mothers reporting on the kids' behavior and the kids reporting on their own drug use and vandalism. And we have not done the genetic interactions yet on that sample. Now, I want to just end talking a little bit on where we really might want to intervene, because part of my life is spent running interventions and evaluating interventions. From the research that I've presented, there are 3 big categories for looking at intervention. The first would be human and economic capital. In this case, we could intervene on family income. We could intervene on parental education. I could change neighborhood conditions. Or in the case of the Great Recession, I could buffer the country in terms of national economic downturns like the one we just had. In terms of family life, since harsh parenting seems to be very important, as does parents' emotional health, which I have not talked about today, but the data are quite convincing. Stimulating activities and materials, talking to children. So I could intervene on those types of variables. And then finally, I could intervene for the child. And this could be in terms of achievement and cognition, and in terms of behavioral dysregulation. And Erica, you should tell me how our time is going, because I can talk a little bit about these or just leave it here. Okay. Okay. Because there is a huge, I could have done a whole lecture on, given what we've learned, and what interventions have we tried and what ones have worked. Family income, there is data suggesting, but it's not experimental, that kids' outcomes are affected a little bit by about $3,000 to $4,000 of extra money. This would be for low-income families. And so now the question is, if we did a randomized trial giving families money, would we get the same effects that we see in the longitudinal data? And a study is being started by my colleague Greg Duncan to look at this issue. We are doing some work with subsidized housing in New York City. I'm in 16 buildings, and this is for not poor families, but families who are near poor. Well, they're between 20% and 50% of the income distribution. New York City, because it's so expensive, families in that part spend much more than 30% of their income on rent, which is more than people have deemed is a good measure, amount to spend. In any case, we have lotteries in New York for these buildings because they're subsidized heavily. And we probably have, at this point, 40 families applying for every one that gets in, showing there's a huge demand. In any case, we are in 16 buildings. There are 16 separate lotteries. And in fact, by heavily subsidizing the rent, you actually are giving people income, and you're giving them about $6,000 a year. This is particularly interesting because these families are all working. These are not poor families. This is not public housing. So we're looking at family income in a slightly different way to understand when you get into the subsidized housing and your rent drops and your income increases, what happens to children, what happens to families. The one thing I can say is the parental stress drops tremendously and the harsh parenting drops. And we still haven't, we're still in the field, so I can't talk yet about what we're finding on the actual expenditures on children. So that's one pathway. And we don't have enough experimental data to see if our longitudinal data are right. The second has to do with parental education. There's some suggestion from the longitudinal data that parental education matters. It matters actually more than family income. So we have a trial going on in Tulsa, Oklahoma, where we are offering incentives and coaches to help mothers whose kids are already in Head Start to go back and get either education, or what we're really trying to do is get them into jobs. So we are training these mothers for CNAs and IT in the health sector. We're dealing with the health sector. And our theory is, one, it makes me think of Kevin, because without the incentives, I'm not sure this would work, because it adds a lot of stress if you're a poor mother and you're expecting them to go to school and work, because all these mothers are working. So anyway, we're trying to see on the child side, we've shown that a huge percentage of our moms are finishing one of the programs and getting a job in the health sector, which is great. And now we want to see, is that going to affect the kids, right? Because that's many of the earlier parental education trials that were done 10 years ago showed very few effects on the parents and very few effects on the kids. But we've made, we've kept 90% of our families stay in these programs, which is huge. So if we don't get effects on the kids, actually it's going to be fairly upsetting in terms of what we believe about can you change parental education and change parenting behavior. Family life, a lot of interventions on home visiting, trying to alter harsh parenting, trying to reduce parents' depression, and trying to do more on stimulating activities. My read of the evidence, again, some of the work I've done and some of the work a lot of people have done, is that our home visiting programs are pretty effective at reducing harsh parenting. They are somewhat effective on changing what parents do with kids, but less effective than we'd like. And I think the jury is out on depression, mother's depression. So we can make effects on harsh parenting and stimulating activities. Interestingly, though, these home visiting programs, the vast majorities don't show effects on the kids. So the question is it because you need a bigger effect on harsh parenting to get an effect on the kids? Or is there something else that we ought to try to be doing in home visiting programs if we want to affect the kids? Some people in the field won't agree with me on how I read the home visiting literature. I've written a couple of reviews and done a couple of them myself. So I think the jury is out. Third, really, are programs that directly target the kid. These are early education programs. These programs can be incredibly effective in altering kids' trajectories in terms of school. New programs are focusing specifically on behavioral dysregulation. These are fairly new, but the few programs we have are showing big effects. The problem with our preschool education programs is that a lot of these effects, while they're pretty big right at age 5 or 6, they still can be seen at age 10, but they fade out by age 18. And so a lot of us are really focusing on which programs are the ones that are likely to actually show sustained effects for children through age 18 and into adulthood, and which ones will not. And I'm going to leave right there. Thank you.
Then if anyone has any questions, you could go to the mic.
Thank you very much. Paul Gast, NIH. With your Fragile Families study, my question has to do with the concept of resiliency. And it seems that the literature shows that telomere lengthening or shortening in parents with special needs kids, some fare better under the same stressful situations as others, and they seem to retain the telomere length, and they attribute that to a concept of resiliency. So it seems that with all of the measures you're taking, you actually have an opportunity with these children to maybe unpack and further our understanding of this concept of resiliency. Can you speak to how you're approaching that in your study?
Yes, we're doing 2 or 3 different things. Clearly, you can't do that with 40 kids that we've presented on. But now that we have a couple thousand, we're doing, with the telomere length, we're starting 3 types of analyses that relate to your question. The first is to look at cumulative risk in the bigger sample, and then see if you get moderators for kids who received positive parenting. That would be an example of resilience, right, that comes through positive parenting. Because just because you have a lot of risks does not mean that some parents aren't warm and aren't talking a lot. So that's A, to look at resilience. And then the B would be really the genetic sensitivity issue that I showed that interesting interaction. So I want to understand with the bigger sample if we continue to get that interaction that shows with certain sensitive genetic alleles, some kids are, if you will, protected from the cumulative risk. So the way I'm looking at resilience or protection are, 1, through what I'd call positive parenting, even in the face of poverty and difficult conditions. And the second would be this, if you will, genetic resilience, if you will, in terms of the sensitive alleles. Because theoretically, we should see in our 2,000 kids, we'll see if it holds up, that there is this gene by environment interaction. So those are the 2 analyses we've started already to look at those. And the third, and I don't know, gosh, I don't know when we'll get to this. all these approaches are variable-oriented approaches rather than person approaches, where you take different patterns or different subgroups with different trajectories. It's a very different way to look at the resilience question, where you identify kids or subgroup of kids that don't show the problem, right, as opposed to looking at the variables, and then try to understand how those kids are different, what their life course was that's different. And we've used some approaches, some people call them tree classifications. They have a lot of names, but with Bert Singer to try to do more of a person-oriented approach.
Thank you. You're also doing endocrine measures as well, right? So you could do some transections between different variables, or no?
No.
Okay.
don't make, you'll make me cry. No, we're not.
Sorry.
We're not, and I did all this puberty work, so it kind of killed me, must tell you, that we couldn't do the endocrine work, and we're not getting immune function. What can I say? You can only do so much in one study. We are doing methylation. That makes me happy. So we'll be able to look at methylation differences between 9 and 15, because there may be some children, right, between the two time points that show differential methylation. Maybe an immune function would be a good guess of where we may go with that. We'll see what the methylation data look like.
Thank you so much for a fascinating talk. And what was
Thank you.
extremely fascinating for me was with your biological interactions. You had mentioned that they were in boys. Can you talk a little bit more about why boys, not girls?
We're not sure. Actually, we have a paper that just came out that I was worried about time, so I didn't bring it, where we were looking at these sensitive kids with sensitive alleles, and looking at fathers leaving the family and fathers coming into the family. We actually have some cases where the dads weren't there and they came in later, the biological dads, right? And we looked at how all that related to aggression, and we got effects of fathers' entrances and exits just for the boys on aggression, not on the girls. I mean, you get them for the girls, but they're not significant. They're in the right direction. And we have big samples, so. And then we found the sensitive allele effect for the boys, right? So if they have the sensitive allele and the biological dad comes in the house, their aggression scores go down. And if a dad leaves the house, if you have the sensitive alleles, they pop up, right? And we're still not clear why boys, and we get the Great Recession effect for boys and not girls. And trust me, I looked 6 ways to Sunday. And I don't know whether, for the Great Recession effect, I don't know, are boys more affected by harsh parenting than girls? That shouldn't be the case. Boys actually get more harsh parenting on average. Boys get spanked more than girls. So we're still, to be perfectly honest, going, what is going on? And we haven't done the telomere work with girls in our first paper. And the reason we didn't is because people have actually suggested from the Romanian orphanage data, I don't know if you've seen that data, that the telomere length story is different for boys and girls there. So we went, oh my gosh, we better look at boys and girls separately. So the telomere length, we haven't done that, so stay tuned. But given the Romanian data on the telomeres, oh my gosh, that's why we're starting to do more work with the boys and girls totally separately. Also remember, when I'm looking at age 9, 25, 30% of my girls have started puberty and about 2% of my boys have. So, and I used to do puberty research in my old life, so I'm starting to do it again because the kids are 9. So with the girls, I want to go back and start thinking about, okay, what's going on, because I've got so many of the girls who are, they're mostly Tanner 2 or 3. They're not menstruating yet, but you know, they're not Tanner 1. They're not. So that's another piece of the story that might be important given this age, right? Because the Great Recession had to be age 9 because that's when it happened. So I've got more. I'm trying to get a postdoc who's really interested in puberty to start looking at all these puberty issues to see if that is an quote-unquote explanation or not. But luckily, there's more to look at, right? Think of it that way.
Olga Brashnik and Katz, thank you very much for wonderful presentations. Actually, the question that I have are to both speakers.
Oh, good.
And the sustainability of different intervention is a big challenge.
Yes.
And I wonder if you consider or if you use some alignment between personal and family and cultural values and the interventions that you propose to different groups.
In early education, that's a huge issue. Should you tailor interventions for parents or children, think 4-year-olds now or 3-year-olds, in terms of cultural? And my answer is no, which will probably surprise you. I get a lot of pushback on that, and I'll tell you why. The reason I say no is because, for better or worse, in our society, the things that matter for kids to do well are achievement in school. And if you want to increase kids' achievement, you're going to have to focus on the behaviors that we measure and value. That might not be good from a cultural standpoint, but it's practical. I'm a really practical researcher, so that's what I would do. Now, you could argue back to me, and that's good, I'd go for that. Well, let's say I want moms to talk more to their kids. Let's say that's the behavior I'm trying to look at. Maybe I should be doing different things for different groups to increase their talking, right? So you could make that argument. But I would say, to date, we have seen no evidence of any of the culturally based interventions making a difference on kids' achievement. The ones that have made a difference are the ones that focus very heavily on middle-class speech.
Kevin, did you want to come up and answer that one? Sure. Before we take the next
Not sure that's good, right? But I am practical.
We've been trying to begin to approach this from a different lens, which is less from the standpoint of cultural background and more from the standpoint of letting people design a program that's consonant with their own goals. And in essence, that's how we've been trying to think about it. You know, a lot of the programs out there are really one size fits all, which obviously has some disadvantages. But in many cases, when we think about trying to harness people's own intrinsic motivation and their goals, to really think about trying to see if we can create programs where people set their own goals, then they may be more likely to achieve them than if we set them for them. And so it's a way to get at what you're talking about, but it's a little bit of a different approach.
Hi, Jim Griffin, NICHD. Hi, Brooke.
Hi.
I would note that 20 years ago, if you made that statement, you would have
I would have
literally
been-
been burned at the stake.
Yes, I know. I know that.
Well,
and
I was
say
right
it,
there.
and
with
I
you.
didn't say it 20 years ago. But
Right.
I actually. Well,
Right.
keep going.
Yeah, no. Well, you know I didn't. Flame retardant. But
Yeah.
could you say a little bit more about with behavior dysregulation? I'm assuming you're going at executive function skills and
Yes,
things. But
I am.
But if you could say, because that involves positives as well as negatives, whereas behavior dysregulation tends to sound a little bit more just like, stopping bad behavior.
I know. Actually, on some of my earlier slides, I've changed dysregulation to regulation. If we went back, you'd see I'm going, for just that reason. I went, it's too negative. And yes, what I'm talking about here, and Jim knows this literature, there are not that many, but developmental psychologists who are developing interventions to focus on executive function, which is planning and attention. And some of these interventions that have been put into the field have been very effective, and it's really exciting. I'm not doing the research. I'm the consumer of the interventions, and I'm loving the research. Other people have tried to focus on reducing aggression as opposed to increasing executive function, planning, and attention. I would say in general, my read of the literature is those have not been as successful as some of these new interventions, planning, attention, and focus. So what I'm finding particularly exciting in the preschool education field is how people, and the Head Start is doing this, they're trying to actually get people to bring those into existing programs, some of these new techniques. And we'll see, you know, when they're taken to scale, that's the question that Kevin was raising, it's the scalability. When we take some of these new executive function interventions to scale, will we still see effects? Big, big issue. But I think it's one of the most exciting things happening in preschool education. So.
Does anybody have any questions for either of our speakers? Then I'd like to, for all of us, to give our 8th Matilda White Riley awardees one last round of applause.